A man in his 7th decade of life presents 2 months after coronary artery bypass with increasing dyspnea at rest. On exam by the otolaryngologist, he was found to have a supraglottic obstruction of his airway. Though he was scheduled for elective surgery, he presented the weekend before with increasing dyspnea, which improved with humidified oxygen and steroid therapy. Because of concerns over the nature of the supraglottic stenosis, the potential for difficult intubation, and the need for a clear surgical field, a decision was made to use transcricothyroid membrane, small catheter, oxygenation, and EVA ventilation. In the event that there should be difficulty with the planned transcricothyroid membrane airway control, the patient was prepared for awake intubation. 15 minutes prior to coming to the operating room, the patient received 0.2 milligrams intravenous glycopyrrolate and nasal spray with oxymetazoline. In the operating room, local anesthetic was applied to the nasal cavity and nasopharynx and to the oral cavity and oropharynx. A local anesthetic skin wheel was made over the surface landmarks of the cricothyroid membrane. The same needle was used to identify the cricothyroid membrane and aspirate air from the larynx. Local anesthetic was injected into the larynx at this time. A 14-gauge Ravussin needle was inserted through the cricothyroid membrane under constant air aspiration. Once air was aspirated from the larynx, the plastic catheter of the Ravussin needle was advanced. After a second aspiration of air from the larynx using a saline-filled syringe, intravenous anesthesia was induced and oxygenation and ventilation commenced using a vent-train device with expiratory ventilation assistance. For the remainder of the surgical procedure, anesthesia was maintained using total intravenous anesthesia, including an intermediate duration neuromuscular blocking agent. Suspension laryngoscopy was placed. During the course, adequate gas movement was monitored through subtle movements of the chest wall, misting in the vent-train clear tubing during the expiratory phase, sustained oxyhemoglobin saturation, and a non-quantitative capnograph waveform. Vent-train oxygenation and ventilation was managed with a 1-to-1, 1-second inspiratory and expiratory phase, allowing for an equilibration phase every 5 respiratory cycles. When a stable plane of anesthesia was achieved and the suspension laryngoscopy in place, resection of the supraglottic stenosis commenced. A protecting platform spatula is placed behind the stenotic area. The surgical laser is now used to open up the stenosis. Cold knife scissors and a balloon dilatation technique will also be used. When the stenosis has been adequately resected, the suspension laryngoscope is removed. Total intravenous anesthesia is now stopped. Transcricothyroid membrane oxygenation and ventilation will be continued until the patient begins to breathe spontaneously. The patient emerges from anesthesia, and the transcricothyroid membrane catheter is removed and a Band-Aid is placed.